So everybody who's already online, I'd like to reintroduce to you Dr. Greg Comadera. Those of you who met him last fortnight will understand who he is. So he's an intensivist and an emergency medicine specialist, and a man of great realistic practicality in intensive medicine. And tonight's he's going to be giving you a journey through blood gases. So over to you, Greg.
Right, good morning, good afternoon, ladies and gentlemen. You'll be on all points of the world. My job tonight is to try and make some sense for you out of point of care testing. So we're going to do this in some pretty broad brushed approaches to give you something that's going to work for you when you're doing ward call. So we're going to look here at what's on the thing you're going to get. What do you actually need as a resident for the simple tests? And then what we can do when you ring someone like me with those raw numbers, which is beyond what I expect of you, but you can see where this can then go. Next slide. Okay, this is an arterial blood gas. You see it's arterial, it's the gold standard, it's the stuff you've all learnt in the textbooks. And basically it's going to tell you what's wrong with their lungs. It's going to give you some metabolic efficiency by way of acid base. It will give you the crucial electrolytes, and for your purposes, will give you what the hemoglobin content is. So you get a fair amount of information out of one point of care test that would take you about 2 minutes to run. Next slide. You don't need that. This is the test you need. You need a venous gas. It's easy to get. You don't have to jag an artery, and you do not care what the oxygenation is, ladies and gentlemen. There's an oximeter goes on the finger, and either 200,000 years of evolution is wrong, or let me tell you, those sats say 90, your PO2 is 60, because it is for everyone else in the world. So accordingly, for what you need is a venous gas, because as you'll see, it will give you alveolar efficiency, because you really only care about the CO2, to be honest. We've got a non-invasive thing called an oximeter. You get your hemoglobin content, and the metabolic efficiency and crucial electrolytes remain as valid. The advantage for you is you do not need any manual dexterity to get this. In fact, if you pull blood for other tests, you can pull this at the same time, put it into a blood gas syringe, and in 2 minutes you will get all of this. I would therefore put it to you that base excess and what you're going to need for this and what we'll do is going to be more than adequate for you as a ward call resident. Next slide, please. Indeed, here are the comparators. And as you can see, if we take away the PO2, which we don't need because we've got an oximeter, you will see pretty much the rest of the numbers are pretty much the same. The CO2 is slightly higher, but it's reliably slightly higher at about 5 to 7. So provided we factor that in, ladies and gentlemen, you're going to get everything you need out of a venous gas, and that is vital. The albumin there is 4 because it's measured in a different framework of ours. It's just a nice comparative table. We would use 40 grams percent for what we use. So next slide. For example, here is what is on them. On a blood gas machine, is there a problem? Yep. Gee, we get that in a venous gas as well. Because in a venous gas, we will get a PaO2, but it'll be measured by a pulse oximetry, which for you is enough. We're going to get lactate, we're going to get base excess, you're going to get urine, or you're going to get creatinine. Next generation's probably got ketones as well, and you get chloride, as we'll come to. You know, chloride and you know lactate, you can find ketones in 99.9% of your acidoses, metabolic-wise, are going to be one of those big 3. Where the problem is, your AA gradient, you can still figure out because it's going to be grossly good or bad, and we'll come to that. Oxygen affinity, you don't need to know. You can't change at your level, and therefore is not relevant on either, but it's there. The cause of the problem, I've got something called a P50. You do not need to know that either. For your purposes, suffice all you need to know is what the absolute hemoglobin level is. And as we talked about last time, 8, if you're stable, is more than adequate. End organ function, we've got there on both. And the important electrolytes, sodium and potassium are our potassium is our preload electrolyte coupled with magnesium. Calcium is both our contractility electrolyte and factor 4 for bleeding, chloride because we resuscitate everything with chloride, and sodium for your brain. As you can see, out of a venous gas, you are going to be able to get everything you need to function as a very competent ward call resident. Next slide. So here are the two gases here, and what we're going to do is look at them and we're going to pull them apart for you. We're going to look at the lung aspect, we're going to look at the metabolic aspect, we're going to assess the hemoglobin in amount only, and we're going to assess the important electrolytes. And to be honest, the last two are fairly simple, as we'll come to. We're going to do it right at the end for your recipe for what you need to achieve an award. Hemoglobin, suffice to say, 8's fine unless you're bleeding actively, in which case you go below 8, so we don't let you bleed down to that. And the electrolytes, normal is fine, but I'll give you the numbers at the end. Next slide. Let's look at the lung aspect. Next slide, please. Lungs, much has been written about it, but this is the way an intensivist thinks about it. All lungs do they are a dialysis machine. We're going to put gas on one side that you breathe in. We're going to put blood on the other side, which is pumped around. And we are going to have a membrane across which gas goes one way, oxygen and CO2 the other. And it binds to hemoglobin. That's it. Your first pump is your diaphragm, which moves the air in and out. Your second pump is the heart, which moves the blood round and round. Consequently, that's all you need to know about lungs. Okay, so as a concept, lungs are phenomenally simple things. It is dialysis. And indeed, when we think at a more advanced level of safely ventilating patients, that is how we think of safe lung ventilation. We do not want to rip the membranes apart, nor do we want the pump to be embarrassed. And when that fails, we move to heart-lung bypass if we need. Next slide. Here is a lung dialysis machine I prepared for you earlier. What we have is a barrier in the middle. We'll call it an alveolus with little cells there. On one side, we're going to have inhaled gas. The only way we can move that in real life is either your diaphragm, as you all are doing now, or a machine, as we do. And the other one is we have to move enough blood the other way, and that's done by the heart. End of story. That is our lung, and that's what we're going to talk about when we talk about our lung efficiency. Next slide, please. So what we have here is a concept. Please do not get head up with this. This is physiology. You do not need to know anything much about it except what I'm going to tell you now, and you can then look at the diagrams. Think of your lung as a tall bit of sponge, which is hung from a hook. We'll call it the top of your chest. And in the middle of that, we're going to put a water pump. We'll call it your heart. The bit at the top, last time I looked, water doesn't pump well uphill, does it? Hence, that bit must be better ventilated than it is perfused. The bit in the middle is Goldilocks. We love it because water flows horizontally. The bit down the bottom, the water flows well downhill, but we're going to crush the lung on its own weight. Conceptually, therefore, the bit at the top is called dead space. It is ventilated and it is not well perfused. The bit at the bottom is called a shunt. It is tremendously well perfused, but the alveoli aren't open. Once we get that concept in mind, next slide, you will see, therefore, that we produce what is called an AA gradient. Big A for what's in the alveolus, little a for what's in the artery. And that is made up by the combination of the dead space at the top and the shunt at the bottom to give you a gradient across the whole lung. Now, in real life, there are anatomical components to both of these as well. But since we're not going to build any of these in the 10 minutes it takes you to get sick, or the weeks you're going to be on a ventilator, then for practical purposes, the anatomical components, for example, your mouth, your trachea, your bronchi, are all dead space, but you're not going to grow any more. So that number's irrelevant for when we look at if you're getting better, worse, or the same. The trend is your friend in dead space. Similarly, with a shunt, you're not going to make any more bronchial arteries that go directly back towards your left ventricle. Hence, since we're not making any more of those, we can use the change in the AA gradient to tell us what's going on in the lung units themselves. So the concept remains valid. Is everyone reasonably happy with that? Hannah's got her little hand on her head. Is that, oh my God, I don't know. Oh my God, don't ask, Hannah, or I was just had an itchy head.
No,
Oh, okay.
good. All good.
Right.
Got it. Thank you.
All right. So we end up with a normal AA gradient. Now, that's the real formula, is age on 4 + 4 if you're over 30. In reality, we are talking about big difference numbers in this game. And 20 remains end organ everything for your body for the rest of your life. So here's a nice little takeaway for you. When in doubt, 20 is a good number. For what it's worth, it's intracranial pressure when we do trauma, above which we ask neurosurgeons to put a hole in the head or a drain. It's intraocular pressure above which you get glaucoma. It's AA gradient we've talked about. For our purposes, we're going to use it for CO2 difference if we can measure in and out, as we'll come to. It's also left ventricular end diastolic pressure above which you get pulmonary edema. It's intra-abdominal pressure above which we want surgeons to do laparotomies and make a hole in their belly. Otherwise, your kidneys don't work. That's compartment pressure in limbs above which you get compartment pressure and ischemia. In reality, it's transcapillary pressure. 20 becomes end organ everything in the body as a reasonable concept. This will become important because we're going to draw some big pictures together. Next slide. So, lungs in effect are dialysis machines, hence we better be able to measure what's in and out. Because if the AA gradient is more than 20, we have a problem. But we don't know whether it's because oxygen can't get in, a shunt, because we're trying to put it through flooded or collapsed tissue, or CO2 can't get out through dead space. But we can measure CO2 being expired. And those of you who have been to emergency departments see we do this quite commonly now, lying people on their side who have had an overdose, and we can measure their end tidal CO2. So if I can measure the CO2 in the blood, and I can measure the CO2 coming out, and that gap's more than 20, I've got to have a problem here with dead space. If it's 20 or less, my problem is a shunt. And that's the way we tell which of the issues it is. Hannah's going, yep. Okay, so think it through, Hannah. Those of you who drink soft drink, what's the bubbly stuff in soft drink? It's carbon dioxide, isn't it? It bubbles out through water very well. So flooded lung, shunt lung, blood in lung, pus in lung, heart failure lung, until the person's exhausted, the CO2 in the blood will be pretty much the CO2 coming out because it bubbles out the minute it gets to any area of flooding. People with COAD or asthma, they can't get the CO2 out because those areas are not perfused. The pressure's too high, the area is not perfused, so they get big gaps, and that's dead space. So we'll come to that in a little minute. But in effect, we use that difference to tell us the problem. Next slide. So the types of hypoxia, if our AA gradient is more than 20, we have a problem. We just don't know whether it's CO2 can't get out or oxygen can't get in. If we can get to it, we look at the CO2 to CO2 in blood to CO2 excretion difference. If that's normal, it's got to be an oxygen can't get in, because we figured out the other one's getting out, isn't it? Done, finished. Now, in real life, it's not as hard as that thinks. We're going to do 2 different types of breathing and you'll get the concept. Next slide. So here is some maths we're going to make simple for you. The AA gradient, if we do some jiggery pokery and it's down in the box, don't worry about it. Multiply the percentage oxygen your patient is breathing by 7, and that's rough enough to be what should be in the alveolus. Because in reality, the real formula is atmospheric minus water vapor minus what we measure minus PaCO2 on 0.8. It's close enough to just multiply. If you're on 30% oxygen, the alveolar oxygen should be 210. It's not going to be far away from that for what we need. That's the easiest way to do it in your head, because the difference is either going to be grossly more than 20 or less than 20. It ain't going to be 21. It ain't going to be 22. It's either going to be 50, 70 or normal. So once we accept that, and 20 is a robust number, this becomes a little easy for us. Then we look at the CO2 difference and we can figure out where the problem is. However, next slide. What we can do though is now think of the type of respiratory failure, and you can see even without the CO2 difference, you can generally figure this out. So if I have flooded lung, you're profoundly hypoxic. If you go to this, just go to back to the slide above, slide up, look at that formula. If I give you a fixed amount of oxygen, the only way when you get sick, you can increase the oxygen in your blood is to decrease the CO2, because you're breathing a fixed percentage of oxygen. Is that correct? So I got to make that gradient higher, and the only way I can do it is to get the CO2 lower so that I make the alveolar oxygen higher. So now go to the next slide. In a shunt situation, I want you all now to breathe as we will a shunt. I want you all to breathe out as far as you can, all of you, as far as you can. Now, I want you all to put your arms as tightly around your chest and belly as you can, as tight as you can. And I want you to breathe in and out against that whilst you're tight around your chest and belly. That is shunt breathing. That is heart failure breathing. That is pneumonia breathing. That is pulmonary hemorrhage breathing. That is collapsed lung breathing. It is a high work of breathing, high rate, low tidal volume, low CO2 until you get tired. Now, when you get tired, your raw CO2 will go up simply because you are now exhausted, but the gap will remain the same. However, it is fairly obvious the way that pattern of breathing is. Now, if we go to the type 2 classic COAD breath, I want you all to take the biggest breath in you can. Hold it. Now breathe in and out on top of that in shallow breaths. That is asthmatic breathing. That is COAD breathing. That is a completely different pattern of breathing. That is classic type 2 dead space breathing. Your end-tidal CO2, PCO2 difference there will be huge and stay there. The reason this is important is you will all be told until now that type 2 respiratory failure is a high CO2. Unless you now grasp the difference, you'll kill people if you just use that stupidity. Type 1 respiratory failure that gets exhausted will have a high CO2 in the blood. They are exhausted. The gap will be still normal CO2 gap. Once they're exhausted, the default for these people is intubation and ventilation, not BiPAP. COAD will do well because it's a CO2 ventilation problem, not an oxygenation problem. will do well with non-invasive ventilation by and large. So both will have a raw CO2 number which is high. The COAD because it is classic type 2 failure. The exhausted pneumonia, the exhausted heart failure, the exhausted pulmonary hemorrhage, for whatever reason, will eventually get a high CO2 in their blood. But their entitled CO2 likewise will be high and the gap will remain normal. That's why it is important to look, if you can't get an end tidal CO2 and it is non-invasive now, if you can't do it, the pattern of breathing is your giveaway. And they are completely different. Important to grasp. Next slide. So we've assessed the lung aspect pretty easily, and that didn't take long. You look at the patient, you look at their pattern of breathing, you do an oximeter, you look at their CO2, and you can pretty much figure that out in a couple of minutes. And that can be done off of venous gas because the oximeter is our friend, as we said, on the arterial. Let's now spend some time on the metabolic aspect, which probably scares you all and shouldn't. Next slide. The metabolic component is valid on both. So we can use pretty much the same numbers on both. When it comes to some figuring out, we're going to use a slightly higher normal for our CO2 for our various rules we'll talk about, but even they are not that hard. Next slide. These are the rules. Do not learn them, okay? I don't get out much. Sadly, I do know them, but I do this for a living. You can look them up. It is never that time critical that you need to rote learn these rules. Okay, look them up. In our ICU, we've got them on lanyards that people just put around their neck with their various cards. They are observational rules, and as we'll come to, they represent from one spectrum of gas or gas to volatile acid, 11 different equations. Next slide, and I'll show you what I mean. The rules are stupid, it seems, but they are stupid because of the following. That is what's going on in your body right at the moment. There are 11 different equations going on to produce your net pH. We can measure one and one only. Volatile gas in all of its forms. CO2 we can measure, bicarbonate we can measure. We cannot measure any of the others at all in their charged and uncharged forms. So somehow out of CO2 and bicarbonate, we have to figure out what's going on with net 11 equations. And that is why the rules seem stupid. Because if we drive CO2 from the respiratory side, we're going to affect anywhere up to 8 different things on the metabolic side. Hence, we go, oh, the bicarbonate 1.5 times plus 8 is the expected CO2. Well, of course it is if we're driving that equation with 8 other equations plus the bicarb one way, but only driving it with one equation the other way, and all the other 8 little ones change, of which bicarb is 1. So the rules are observational. The rules will work. You don't have to know them at all, except to say, if you want to, you can look them up. That slide is there to show you why the rules seem stupid. We can only measure CO2 and bicarbonate. That's it. Next slide. Now, just go to the slide after that. You should get a little, yep, that's it. Stop there. The strong ion difference, that I'll put anion gap there, is an engineering term for what is the anion gap. So what we learned for almost 100 years is anion gap. If we move into an engineering sphere, is called a strong ion difference, or really pluses and minuses. It's the same thing. So we're going to call it anion gap for what we do. to maintain some integrity. If you look at that, let's have a look at what we can actually measure in these. Well, we can measure CO2. The anion gap we'll come to, but pretty much outside the cell, it's going to be sodium and chloride, because they're the only big pluses and big minuses. Everything else is so insignificant, it's a waste of time. Potassium is 4, magnesium is 1, phosphate's nothing, sulfate's nothing, urea's nothing. And then we come to what's called A tote there, which is really albumin. And an albumin of 40 gives you an anion gap of 12. There's 4 charges on albumin. Pretty much that's 10, and the rest of the rubbish is going to be a bit of plasma protein and not much else. So in effect, from that top bit, CO2 and anion gap and albumin are what's the independent variables we have there. Bicarb down the bottom, the yellow, the orange bit's the only other thing we can measure. So what we've got here outside the cell, if we look at it, is going to be sodium and chloride, is going to be bicarbonate. And from that, we're going to figure out the whole metabolic thing, because everything else is pretty insignificant. Now, just for fun, we could do this inside the cell. No one's that nerdy. But instead of sodium, we'd use potassium because it's the cation inside the cell. And we'd use protein instead of chloride for the negative. But the effect would be the same. So we could still do this inside the cell. We just do it outside because that's what we can measure. Next slide. So consequently, in my world, I'm going to use the raw numbers and an anion gap. You don't need to go that far. So we're going to enter the base excess. So let's go to the next slide. If you remember, we talked about base excess a couple of weeks ago. We'll talk about it again for trauma. All base excess does is remove the CO2 component. We will assume the CO2 is 40 and we'll take it out of the equation. Hence, we are going to get the metabolic process only. Happy days for what you want for a sick patient, because as we're going to come to, and as we saw, they're pretty much always acidemic. So why are they acidemic? Well, at the moment, I can see Makey there, so I'll assume Makey's got a pH of 7.4 because everyone else in the world does. Okay, so you can put your hand up, Makey, you're normal. The resuscitation fluid of everything we use is acid. Normal saline is 5. Hartmann's is 6.8. Salt poor albumin is basically normal saline with a bit of glue in it. It's about 6. So in effect, everything that makes us sick, bar a few glaring examples we'll come to, which get dwarfed anyway, and give you a metabolic alkalosis, make you acid. That's going to be lactate, ketones, or chloride, which will be 99.99999% of everything you will ever see for the rest of your life, making you acidemic. The chloride, because it's the fluid we use to keep you alive. The ketones, because you're starved, drunk, or you have diabetes. The lactate as a marker until we prove otherwise of end organ hypoxia. That's it. So once we know that, we see the base excess becomes our friend. Next slide. As I said, more than 99% of that. So in addition, the patient, the first time you see them, if the base excess is badly negative, they're sick. And what it reflects is at a point in time, they're sick. They should get better with our treatment. The base excess should become less negative. Next slide. So the options become, once we know this, for you in a ward, base excess getting better, patient stable, terrific, happy days, we fixed the problem. Or alternatively, the patient does not change their pH. Now that may be one of two things. For you, it means you ask for help, because until you prove otherwise, you have an ongoing process, or you are still needing to give a shed load of chloride to keep them alive. Either one means you call for help. Now, in reality, the physiology will lag a little bit. So next slide. A young diabetic, for example, that you treat appropriately, the pH won't change for some hours even though you fix the problem, because what you've done is give insulin, give fluids, turned off the lactate, whatever they've got, turned off the ketones and replaced it with chloride. Their pH won't change because you're swapping ketones and lactate for chloride, but the patient looks better. That's beyond what you will need to know as a resident. You ring someone like me who will do some maths we'll come to later to show you how it can be done. That's beyond what you need to do. Suffice to say, if their pH doesn't change or their base excess doesn't change, you call for help is all you need. Now, it is possible, of course, to have a metabolic alkalosis, but it's pretty rare to vomit that much chloride, and particularly as an adult, not be so dehydrated you're going to mask it anyway. It's pretty hard to be just dehydrated enough, but not so much to be shocked. Hypoalbuminemia is almost ubiquitous in our patients, and we certainly see it in intensive care, but it alone is not going to make you sick enough for you to be called. So metabolic alkaloses are possible, but fairly uncommon, except if they're transitory. Because in reality, if you get sick enough, the lactate, the ketones are going to swamp that, aren't they? And then any fluid you give is going to well and truly swamp it because its pH is 5 or 6.8. So it's possible, but not that common. Next slide. All right, so let's look how a combination this can be used, because right now you're going, yeah, this isn't really useful. So next slide, let's see how we go. Here are some flow diagrams I prepared earlier for you that if you follow these, you will always get the right answer, ladies and gentlemen, and there aren't that many. So first up, I'm going to give you the raw numbers that I use, and then the ones following. So each one is going to be paired with the venous gas one, and you can see it works. So in my world, if the pH is abnormal, then I go one or other way. The CO2 goes in the same way as the pH. I've got a primary metabolic process. I apply my rules to see whether my expected respiratory effect is exactly what it is or not. And in my game, and in your game, you have to be exact because the two processes do matter. We follow this, we get the rules. Let's go to your world in a ward. Next slide. Oh, all we're going to do here is use the same. We're going to go, there's pH abnormal. Gee, that seems the same. Venous CO2 of 45. So we're going to be a little bit higher, but not a lot. And you can see that you will get exactly that same result for what you need. And I've given you some numbers at the bottom to be worried about. If it's less than or more than, you need to call because there will be another process. So you need to know almost nothing about the exact numbers we talked about that people have harped on for almost 100 years to make sense out of acid base, to figure out A, are they sick, and B, how well they're doing. That flow diagram will get you the right result. The next slide is just here to show you, next slide. You've got more chance of winning the lotto, by the way, than having a normal pH with an abnormal CO2 because there's 11 different equations. Someone worked that out. It's about 1 in 3 billion chance. Realistically, that is a common thing in my world, but I just put it up there to show you that if the pH is normal and the CO2 is abnormal, you cannot possibly ever compensate. So there's stupid terms, you can't compensate to a normal pH ever. You must have two primary processes, but next slide, because someone's going to say base excess doesn't work. Well, there it is there, and you get exactly the same result if you use base excess in venous gas. It is robust enough to give you the right answer. Next slide. Just so we don't play favourites, the pH is abnormal, the CO2 is exactly 40, which is the exact normal number we'd use for our rules. Not possible. You've got to have two primary processes. In my raw number world, let's look at your world with base excess quickly. Next slide. Oh heavens, look, it's exactly the same. The point I'm trying to get you to see is out of one Venus gas, you can get not just meaningful data, but data that is good enough to tell you, A, they're sick, B, they've actually got more than one process going on, and C, you don't have to jag an artery and you don't have to know a whole lot of silly observational rules. All you've got to know is follow those flow diagrams and then ring for help thereafter, and that's fine. You will get exactly the same answer I'll get. Mine will be more precise and I may find another process or two. That doesn't matter to you, and we've got some worked examples at the end of this that we can do. And if you want, I've spoken to Athol, I've got any number of worked examples we can do one night if you wish, and I can give them to you ahead of time. You can work through them and we can do them as a sort of interactive one at some tute if you want. Next slide. What you need to do in your world is base excess and CO2. That will do you. You don't need any more precision than that. What we care about is there a metabolic acidosis? And secondly, how well are the lungs dealing with it? Full stop. Nothing more, nothing less. That will do. Next slide. Now, for purity, you don't need to know this, but for purity, this is how we model the metabolic part on raw numbers. The anion gap, and your eyes will go counterclockwise, so suffice to say the anion gap is that formula there. And the 12 represents albumin. Charged albumin gives you an anion gap of 10. If we add the bits of rubbish for protein on one side and potassium on the other, it works out to 12. In essence, therefore, all an anion gap that is normal represents is if I swap chloride for bicarbonate. That's it. Since I can't wee out chloride very well, and since we resuscitate with chloride, anytime I need to get rid of a negative charge, it will be bicarbonate. I don't measure what it's replaced with. The gap goes up. That is the high anion gap, and that's all it is. So we come to the next slide, I'll show you what I mean. Leave, that's there for your purposes. I'll come back and refer to that as to what that means, but we'll come back to that one in a minute. This is what I mean by what we're talking about. Let's do the high anion gap ones. Methanol is broken down to formic acid. We don't measure formic acid, it's got a negative charge. I get rid of a negative charge because I need electrical neutrality, which means bicarb goes down, chloride stays the same. Oh, dear whiz, the gap gets bigger. Who'd have thunk it? And that's all that means. Done, finished. Because my sodium remains the same, I'm taking away from that the chloride, I'm taking away from that the bicarbonate. My bicarbonate level plummets, the gap gets bigger. Done, finished. Similarly, uremia with renal failure, ketosis, it's negatively charged, salicylates in their own right, but in fact they kill you by lactic acidosis, starvation with ketones, lactate we already know. Those of you who drink alcohol, yes, you are pickled. You are in acetaldehyde, which is what we keep bodies in to preserve them, so you do get pickled. Ethylene glycol we don't see much of in Australia, but in the Northern Hemisphere it's antifreeze. That kills you with renal failure. It's not the glycolic acid that it's broken down to, it gives you oxalic acid and renal failure. Paraldehyde is there because of neonatal fitting, but also to remind us that almost every anaesthetic agent has got pyroglutamic acid in it. It's why people with We see people on propofol in intensive cares with green urine. We try and get out of it. It's its breakdown product. Iron kills you with lactic acid. Now, if we look at the other side, well, pretty much all we're going to do in all these is swap chloride and bicarbonate. So if we think about it, you vomit chloride and you defecate bicarbonate. So people die from cholera by having defecated out bicarbonate because their bowel has tried to absorb all the chloride. Kids vomit with pyloric stenosis chloride. So your gut is designed to absorb chloride. So let's see, if we ureteric diversion, so someone's got bladder cancer, we take their bladder out, we put a couple of ureters into a bit of bowel, the bowel goes, yippee, all this chloride's coming down, I'll absorb it. So everybody who's got a ureteric diversion walks around with a pH about 7.25, normal anion gap acidosis, because that's what their bit of bowel's doing. It's just doing its job, and the kidney goes, I better get rid of some bicarb, so they get a normal anion gap. Small bowel fistula, if I leak bicarb, I will retain chloride in my kidneys. Extra chloride, we're going to resuscitate everyone with a pH of 5 with normal saline or 6.8 with Hartmann's. There it is. Diarrhea, we lose bicarb. DKA because we resuscitate with Hartmann's and or normal saline. Carbonic anhydrase inhibitors are there because we see it with acetazolamide in glaucoma. We sometimes see it in head injuries because we use it, but glaucoma is the common one there. Okay, but spironolactone will be the other one you will see in your career because it's used as a diuretic for heart failure. Addison's disease gives you renal tubular acidosis type 4. It's hyperkalemic, normal anion gap metabolic acidosis. Renal tubular acidosis, for your exam, anytime you see renal tubular acidosis and you see the word diabetes, tick that box, it can give you all of them. So there's a hint, as can lupus. So if you see one of those two, tick that box because you can't be wrong on your multi-choice. And pancreatic fistula. That list, you don't need to know those lists at all. What they're there to do is illustrate for you that the reality of an anion gap reflects for someone like me what the problem will be just by knowing what the difference is. You don't need to know it. It's good enough you can ring someone like me. Now go back to the slide before. Slide up. Yep. This is here to highlight some of the practical problems with any point of care test. One is albumin. When we get sick, we metabolize albumin. Okay, getting sick, we are not Jenny Craig. You do not, when you are sick, lose fat. Sadly, if that was the case, we'd all be very rich as doctors. We're not. You lose protein, you lose muscle mass, and you burn albumin. So consequently, we expect for most of our sick patients in ICU and your patients in a ward setting there of some weeks, will have low albumins. And we need to correct for that for the anion gap. You do not need to do that at all. You can go on base excess, but that's what I would do to make the numbers make sense. I put it here to highlight the fact that you do not need these raw numbers, but when we do some of the worked examples, I will take you through what it means when we do them. The one you do need to think about sometimes is the pseudo hyponatremia. Glucose is there, it's osmotically active, and if you don't have insulin, it will suck water out of the cells because it can't get in. You take blood, you go along to the machine, and you will get a sodium lower than what it is because it sucked water out of the cells. We do not correct that sodium, we give insulin. And when the glucose goes back into the cell, the sodium comes back to normal. That is the correction there for that. You do not, again, need, yes, dilutional, no, Hannah, it's not dilutional, it's called a pseudo-hyponatremia, but you're partially right. Dilutional means we've added stuff to it. This is water that's come out of the cell because it's been sucked out. The patient remains dehydrated still. We give insulin, the water will go back into the cell. So you're right in concept, absolutely, but think of it slightly differently because just giving salt here won't work. We've got to give insulin and put the water back into the compartment it needs to be. So it's a little bit more precise, because if we don't think of it that way, we'll get ourselves into strife by giving hypertonic solutions when they're impractical. Does that make sense? Is that a yes? No? Hannah wrote, did that make sense to Hannah? Yes. I'm seeing a Mercy put a thumbs up, so that must be on behalf of everybody, is it? Okay. All right, next slide. Next slide. All right, in my world, this is then how I will determine what you're telling me. I will then do some maths in my mind to look at the effect of the chloride, the effect of the bicarbonate, and the effect of the raw number. And from that, we can determine whether the patient is getting better or worse for the same pH. I only flag this for you so that when you query why we may accept someone from ED with the same pH that someone yesterday we said no to, you can see that what we've done in our mind is run this and gone, you're in fact treating them well. The chloride has kicked in, they will wee this out because that ratio is getting better. So it's there for you to understand. It's not arbitrary that we'll say no for one pH and yes for the same one yesterday. This is what we've done in our mind because we have a limited number of beds. If what you're doing is correct, the pH won't change for a while. However, we will be replacing the chloride and the ketone, the ketones and the lactate with chloride. Happy days, the ratio will be going from over 1 down to 0. Happy days. So this is what we do in our mind on the pure numbers. However, we can't do this unless you ring us that they're sick with the base excess. That'll do. Okay, next. So here is the example I give you. DKA patient will present with a classic HAGMA, as some of you will call it, high anion gap acidosis. You give insulin, you give fluids, and it will correct the DKA. The pH will not change, often for some hours. The reason is that you're resuscitating with fluid with a pH of 5. Even if you use Hartmann's at 6.8. So this pH is not going to move for hours, but the ratio will. The ratio will get better. And that's what we will look at to determine, are you winning or not? Can this one wait another 6 hours until we have a bed, or indeed, can it stay there? Base excess won't give you that precision, but you don't need it. All you need to know is, are they sick? So we will ask you for more numbers. It doesn't mean you're wrong. It just means we need more detail. Next slide. As I said, it's a point in an ongoing time. You've identified sick, that's good enough, and that's all you need. Next slide. Do you need precision? No. Emphatically, no. And that's why it's in capital letters. You need to know whether they're sick or not. You're a non-expert. Sick will do. You then ring somebody who can do the raw numbers. Not at your level. You've got more complicated things to learn to do your job than silly numbers like this. Next. So now we're going to assess the hemoglobin and the electrolytes. We talked about that. Next slide, because I will come to it very quickly. Here is how you're going to deal with a sick patient with venous gases. Here is your recipe, ladies and gentlemen. Take patient, add water. Use the pulse oximeter. If it's less than 92% on 6 litres of oxygen, just put them on high flow at 40 and 40. Okay, just cut to the chase and do it. Okay, if the SATs don't get well above 96, you ring for help, because it sure as hell ain't dead space. You've already ruled that out simply, because on that much PEEP, dead space gets better. Next, you use your venous gas. CO2 is your friend for ventilation. If it is high, they are hypoventilating. It's either because they've got flooded lungs and they're knackered, or they've got COAD or asthma. You can tell the pattern very simply. Again, suffice to say, if their CO2 is more than normal, and that's the upper range of normal, ring. Neither should have that. If you think about it, if you have flooded lungs, your CO2 should be low. You're working hard. If you have normal CO2 with asthma or COAD until we decide that we're not going to be intervening much more, that patient too is the type that die in the ward. You need to call for help. Next, the base excess tells you about the acidemia, and coupled with the CO2 will tell you whether the CO2 is appropriate or not. If, for example, and I'll give you some raw numbers, but we can then do base excess. If your bicarb is, say, 10 because you have a diabetic ketoacidosis, your CO2 better be 23 because it should be 1.5 times the bicarb plus 8. If it is 30, this person is exhausted because the right number is 23. 30 is too high. They are exhausted. Their CO2 is high. They either have a pathology in their lung or they're tired. They go to the ward, they die. So we need the flow diagrams to tell us whether the CO2 we're seeing in the raw number you can read is appropriate for the metabolic process going on. Hemoglobin, set and forget at 8. The reality is that if you're bleeding, we of course are going to give you blood long before 8. If, however, you're stable, 8 is about as good a number as there is, and I've got the Cochrane review stuff there for you. So we don't need to be racing in for blood transfusions provided they're in a steady state and not bleeding. Next slide. Electrolytes are there. Sodium is your brain electrolyte. It's pretty simple. You want it to be about 140, 145. If you've got a head injury, as we'll see in a couple of weeks, we'll push it higher deliberately, but 140, 145 is good enough for purposes. Chloride merely tells you how much resuscitation you're using. Think of it that way and you'll be fine. Calcium we need for contractility. We did this last time. You want it to be ionized of more than 1. It's also factor 4. Potassium is there to stop you getting atrial fibrillation. There are 2 ways we can increase cardiac output. One is increasing stroke volume, which is efficient. The other one is having tachycardia, which is inefficient. Otherwise, athletes would all be running around with heart rates of 200 and no stroke volume, and they don't do it, do they? So what we're trying to do is give you a slow, or your patient, a slow, efficient filling time. You want the potassium to be 4 to 4.5 and a magnesium of 1 to 2. Next slide. To refresh the metabolic component, next slide, is that for your purposes. Follow that, you will get the right answer. Next slide. And that, next slide, and that. Now, next slide. Let's do some fun examples. Here we are, ladies and gentlemen. So let's work through this together, shall we? So let's do it with base excess and do it with raw numbers. The way I would approach this is as follows. The pH is at more or less than 7.4. It is less. Therefore, I have an acidemia. Please note the term. The net result will be an acidemia. I may have any number of processes, as we'll come to give me that. I see the pH is 6.94. In my world, the bicarbonate is less than 24. Therefore, it's a metabolic acidosis at least. In your world, you have a base excess of -8. Therefore, you've got a metabolic acidosis at least. Happy days so far. The CO2 for that bicarb, I said to you, we're going to use 45 on your venous gas. But look at our base excess. It's hugely negative. It should be much, much, much less than 45, shouldn't it? Well, in fact, in my world, it should be 12 and 8 is 20. The CO2 should be 1.5 times the bicarbonate plus 8, it's 20. There it is 40, much more than I expect. But remember what I said, you can't ever have a funny pH with a normal CO2 of 40. you've got to have two processes, and we just did them, didn't we? You had a metabolic acidosis and a respiratory acidosis. So if you followed my flow diagrams, the one that gives you that one of 40, you'll see there, and you'd use 45 for your venous ones, you'd have two primary processes. Now, if we want to be really, really, really clever, we see the anion gap's 20. So we've got a high anion gap acidosis, at least, because we use 12. So 20 minus 12 is 8. 8 divided by 16, which is 24 minus 8, the bicarb. In my world, you'd have a combination of a normal and a high metabolic acidosis plus a respiratory acidosis. In your world, you've got a metabolic acidosis and a respiratory acidosis. That will do. All I've done is fine tune with raw numbers what you will get following those flow diagrams. Yes, it is, Hannah, but it's more precise than that. There are 3 acidoses, 2 metabolic and 1 respiratory. The key for you is to recognize the respiratory one, because that will come back on your machine as a green number, because 40 is within its reference range. But if you think about it, can anybody who has a metabolic acidosis have a CO2 that is in the green range? They can't, because they all breathe up, don't they? So the CO2 should be much, much, much less than 40. So you've got a metabolic acidosis and a respiratory acidosis. You're right, there are multiple acidoses, yes, but one of each. Next slide. So, the worked example. 2 primary processes, bicarb less than 24, move in the same direction. The delta gap is what I did to figure out the impact of both the high anion component and probably the resuscitation fluid we'll be using, which would be normal saline. So we have the answer there. If you told me when you rang me this is a metabolic acidosis with inadequate respiratory effort, so hence a respiratory acidosis as well, I would be delighted, because that tells me they're sick and your resuscitation isn't winning. That would be more than enough and very, very safe. Next. So combination there. Example might be ketoacidosis, saline resuscitation, respiratory failure. Well, there we are. This could be any lady you're going to see on metformin coming into your emergency department with a UTI. That'd do. And that's what it will come with. That's what it will look like. Makers staring at me with startled look. But if you think about it, metformin's notorious to give you, in diabetics, it gives you a lactic acidosis as well as the ketones when they get sick. We're going to use normal saline to resuscitate them. And the little old lady's exhausted because she's been at home for 2 or 3 days sick. So she's now not breathing well enough. Perfect picture. Next. Oh, here's a good one. So the pH is more than 7.4. These are arterial because they're all just mine that I've kept over the years. So the pH is high. We have an alkalemia. The pH goes up, the CO2 goes down. So we've got to have a respiratory alkalosis. And the bicarb has gone down appropriately for the CO2 if you do the sums. So this is a primary respiratory alkalosis. Is everybody happy with that? And just do thumbs up, because there's nothing fancy with that bit. I'm now going to trick you. I'm not going to ask you. So this is just a hysterical young lady and she can go home. Is that correct or not? And if not, why not? Hands up for it's just hysteria and the lungs are fine. Hands up for No, it's not, Hannah. It is not. Next slide. Next slide. That's the AA gradient, ladies and gentlemen. Go back to the numbers 2 slides ago. .35 by 7 by 35 will be about 200 and something, won't it? Is my AA gradient more or less than 20? It's much more, isn't it? This cannot possibly be a normal lung in somebody who is purely hyperventilating. We have to have lung pathology here. And this is why PEs get sent home to die. Because that's what it is. Small PE, done. Yep. No, you're right. You're right. So go back. Not Mercy. Who was before Mercy? So whoever was before Mercy made a terrific observation.
Is that
Oops.
because she's on FiO2 of 35% and her PO
Correct.
80?
Well done. Well done. So what we've got, you've got to look at everything. These get sent home to die because her acid base is fine. What's the additional information here? The additional information here is that lung unit cannot possibly be normal. It can't. We're grossly more than 20, aren't we? Our job is to explain that. So when we get a piece of point of care testing, we ruthlessly look at it. And these do get sent home to die in Australia, about 20 a year. Okay, next slide, and then next slide after that one. Keep going, next slide. Okay, so now we're all a little bit going okie dokie. Now we're going to get a bit scared on this. All right. Here's something, we'll do the acid base bit first. pH is green, it's normal. But the CO2 is less than 40. Hence, as we go to our flow diagrams, and when you do these yourself, just photocopy the flow diagrams, use them, and you can go through them, and you will get the right answer. Is the CO2 is too low. So you've got a respiratory alkalosis and a metabolic acidosis. We can do it, I'll do it in my head. The metabolic component, the CO2 for that bicarb should be 38. 21 on 10 is 30 and 8 is 38. You see the CO2 is less than 38. So I've got to have a respiratory alkalosis as well. So I've got a metabolic acidosis. What type? Well, my anion gap is 8, which should be normal. But I know here my albumin is 26. 40 minus 26 is 14. Yes, I don't get out much, sadly. 14 divided by 4 is 3. I'd expect my anion gap to be 8, which is going to give me the 149 and the 120 works because it's all chloride. If I use 12 here, I would get a high anion gap, which it isn't. So whenever you see a low anion gap in the green bit, just go and look for the albumin. It's invariably low albumin, invariably, for your purposes, because pretty much nothing else will do it. All right? So albumin will give you a low anion gap. Steroids can, and steroids do because they tend to push up sodium and bicarb, but pretty much it's low albumin in sick patients for the low anion gap. But if you followed your flow diagram, you would have said we have a metabolic acidosis. Look at the base excess, slightly wrong. And, oh, gee whiz, with that, so my CO2 should be, oh, it's a little bit less than it should be. It's not much, it's a little bit less. Next. That's what I would do in my head, but you don't need to. What's the AA gradient? About 100. So let's go back to the last one. Go back to the slide. No, Hannah, they're the worst terms on earth. Okay, you're either right on the number, no one's partially pregnant in this game. You're going to get yourself into almighty strife saying partial might be, could be, it might be a metabolic with this with a double flip. For God's sake, it's either exactly the number or not. They're appalling terms. because really is a chronic, and I'll give you the ultimate example. Chronic respiratory acidosis is either somebody in the era before we had Lasix, steroids and everything else, or it's heart failure or COAD, sorry, that we've given Lasix and steroids to, because they will give you exactly the same numbers. So they're terrible terms because they don't reflect modern medicine, and they're archaic terms almost 100 years old. So I get them, they're still in the textbook, but in practical terms, they're dangerous. The reason this one's dangerous is we're on 30% oxygen. Your AA gradient is huge here. It should be about 210 minus 70, it's about 130. So I've got a ragingly high AA gradient and I'm getting rid of my CO2, it's 32. This has to be type 1 respiratory failure. So on this one, I'm going to go looking at my lungs. It's either going to be water or pus or red cells in reality, or collapse. There's either no air and I've got a shunt, or I've filled it with red cells, white cells or water. So chest X-ray is my next port of call here, going to look for my cause because that's what this is telling me. Next. Next one. Okay. Normal pH, close enough at 7.35, but slightly low. We've got an acidemia. Now look at this. My base excess is very positive. So I'm going to have a metabolic alkalosis here. I'll do the raw numbers for you, but your base excess tells you that. And a respiratory acidosis, because I've got a pretty normal pH. You can do that off your raw numbers. If I do it myself, the raw numbers sadly are 0.7 and 20 for the, so it should be 21 and 20 is 41, should be the CO2, it's 58. So if I do the raw numbers, it's the same thing. So this is a raging metabolic alkalosis. And you can see that, look at your sodium of 151, much higher than your upper end of chloride. For 151, your chloride should be about 115. So that's we've replaced that chloride of 115 with bicarb, and that's what we've done. Probably this is steroids, to be honest. Steroids or Lasix is about the only thing that'll do that. But you can see with enough Lasix, we can drive you not to breathe, because we're telling you not to get rid of CO2, because chemically we're saying, well, you can't get rid of CO2 because we need to keep all the bicarb you've got. So this is a Lasix infusion that we push too hard in effect. And you can see that you just will stop breathing with enough Lasix. Okay, next slide. It's just a nice, there we are. Oh, and here we are for our person who said, is it chronic? Well, it could be, it's a pure number, or patient could have steroids and Lasix. Now, in our world, which do you think is more likely in the 21st century, ladies and gentlemen? Chronic respiratory failure that we saw 30, 40 years ago, and probably still do in remote areas, and I appreciate some of you will be working in remote areas, or some Lasix and steroids that we'll be giving to someone with some COAD. Which do you think is more likely? So when we said before partially compensated, etc., this is why you need to be very careful. The numbers will give you alternatives to a diagnosis. The rest of your history and examination give you the answer. Next slide. Okay, what do we got here? Is everybody happy now? We have an acidemia. I'll look for thumbs up in pictures. pH is less than 7.4. Is everyone happy with that? I'm seeing a nod from Maker. I can only see Mercy's little bob on top of her head. I can't even see her face. All right, I'm seeing that move. Excellent. And the rest I can't see, so I'm assuming yes. Okay. The pH goes less than 7.4. The bicarbonate is well under 24. Therefore, we have a metabolic acidosis at least. Is everyone happy with that? Yes, looking at your flow diagrams. Okay, I'll do the raw maths. The CO2 I expect for that number of 13 is 13 and 7 are 20 and 8 is 28. Is my CO2 I am recording more or less than 28? It is more. Therefore, I have a respiratory acidosis as well. The fact that it is under 40, or in your case of venous gas 45, is irrelevant. That number needs to be 28. Therefore, whatever is going on here is causing our patient here not to be ventilating well enough. 33 is too high. Whatever's going on, unless we explain it, potentially treat it, we're going to plonk them in a ward where it will continue to get worse and they will die. That's why the number matters. 33 is too high. We have a process driving this, in addition to whatever is the underlying acid process. So let's look at our metabolic acidosis. Oh, look, your base excess is minus 13. We agree, happy days. And we see that it is a normal anion gap acidosis. So this might be some form of gut problem. It might be an effect of resuscitation. But we still have a lung problem here as well, don't we? Getting CO2 out and we're getting exhausted. The CO2 is too high. Now, ladies and gentlemen, we're going to look and see, is the lung unit normal? What is the AA gradient? Is it more than 20 or less than 20? I'll give you a hint. 30 by 7 is 210. 210 minus 90 is 120 minus CO2. No matter how high that is, I still think it's going to be more than 20, don't you? So we must also have a lung problem here as well. We have to. Now can you see sending this person to the ward is a catastrophe? We have a lung problem that on that gas, this person is already failing. Their CO2 is too high. And we know their lung is not normal because the AA gradient is high. Does that make sense to everybody? We don't need a chest X-ray yet. We know where our problem is going to be. The chest X-ray will now confirm the problem, which we can find on a point of care blood test. Happy? Yep. Yep. Now, if this person was on 30% and you stuck an oximeter on this finger, it would read about 96%. Okay, if you did a venous gas, the oximeter is going to read 96%. What should anybody's oxygen sats be on 30% oxygen? I'll give you a hint. It's got 3 digits and the first one starts with 1 and the next one's got a 0 and the next one's, oh, well done, Nabil. Oh, go girl, I say, well done indeed. So it's pretty obvious if you stuck oxygen on someone and as you have, and it's still 96%, this sure as hell is not going to be CO8E. It's going to do far better than 96%. This is going to be type 1 respiratory failure. This is shunt because you put oxygen on and you've got really not much response. This is archetypical pneumonia pattern, archetypical heart failure pattern, whatever. When you looked at the patient, they would have the following breathing pattern. Everyone breathe out, hold your chest as tight as you can, breathe in and out against that, and that's what they'd be looking like. And they're getting tired. That's what they're looking like. Next one. Normal anion gap, the AA gradient we've talked about. Next. Okay, here we go. FiO2 of 1. Okay, you can't get that in the ward, but we can. We're ventilating them. All right, I'll do this again. pH is less than 7.4. Is everyone happy with that? Therefore, we have an acidemia. Is that correct? Yes. The pH and the bicarb go in the same direction, which is low. And that will fit your base excess. So you have a metabolic acidosis here. In my world, I would expect the CO2 to be 1.5 times the bicarb plus 8. 13 and 7 is 20, 28. It's more than that. So I have a mild respiratory acidosis as well. You're not going to quite get the same accuracy with base excess, but you don't need it for your sick patients in a ward. Let's look at the type of metabolic acidosis we have. Our anion gap is 15. I put albumin of 22 there because it's a sick patient. 40 minus 22 is 18, divided by 4 is 4.5. I expect an anion gap of about 7.5. If I work that out, I will get a combination of normal and high anion gap. The normal being chloride, you can see, is too high at 115 for 143. We've used saline to resuscitate our patient. And you see my lactate is 4.5. Go to the next slide. And that's what it really means, because I use 7.5 as my anion gap when I do my sums, because I've just corrected for being sick with no albumin. All I want you to get out of this is the base excess will give you a metabolic acidosis. If you use the flow diagram, this patient is clearly sicker. What would you think the CO2 should be for a bicarb of 13? It should be well under 45, shouldn't it? This is getting close to 45. This is way too sick. Now, if we go back again, what do we think of the AA gradient? This one's easy. 100 by 7 is 700. So 700 minus 450 is 350. 350 minus a bit of CO2. Yeah, but I think we've got problems in our lungs, don't we all? Because that AA gradient's well over 20. And all this will be an early blood gas that we've done after we've intubated someone with pneumonia and has been getting normal saline resuscitation. That's all this will be. But you can see the effect of even pre-oxygenating someone with on 100% oxygen will not get your alveolus anywhere up to 700 because it's going to have fluid in it. And this then brings me back to what I gave you with the recipe, ladies and gentlemen. Remember, I said to you in that recipe, if you need more than 40 and 40, you call for help. The reason is, if we need to ventilate them, we need to buy space. And hence, we need space to pre-oxygenate them, space then for the time for the paralysing drugs to work. So we don't let you go more than 40 and 40. PEEP, no. You're going to get a bit of that with 40 and 40, but we do not want you to use more than that, Hannah, because we need the space for whatever's reserved there to fill with oxygen so our drugs can work. So high flow will give you a bit of PEEP. Here, this patient would probably end up eventually on about 15 of PEEP, but that's another lecture. The point I want to get you to see is putting someone on a non-rebreather, which is as close as you'll be able to get to an FiO2 of 1 in a ward. If someone has pneumonia, you won't even get close to those numbers. And that's how bad a shunt can be. You'll get the same with heart failure as well. Next slide. Next slide. All right, here's a little bit of a simpler one, I hope. We have an alkalosis. An alkalemia. See, this pH is high. This is the same one we did before. So hopefully, ladies and gentlemen, we'll get it right this time. pH is 7.51. We've got an alkalemia, CO2 of 26, bicarb of 21. Those numbers are right. If you go to the next slide. Expected CO2 is normal. This is pure hyperventilation. Who wants to now, who before said we needed to look at the top number? They can answer this time and answer for me. Who went, oops, I didn't look at the top number before. So go back a slide. Look at the top number of 35. Can this be pure hyperventilation? Yes or no?
No.
No. Well done. Well done, you. That's exactly correct. It can't be. So what we're seeing here is why we need to look at everything. This lung unit cannot possibly be normal. Can't be. Because the AA gradient is high. This isn't pure hyperventilation. This is an abnormal lung unit. Our job is then to explain it, isn't it? So let's go to the next slide. Next slide after that. So if we go back a slide, this is just the PE one again with more numbers for you that we did before. It can't be pure hyperventilation. But look how easy it would be, go back to the slide again. Look how easy it would be for you to send that home. Oxygen looks fine, her oximeter would look terrific. Until you realise she's on 35% oxygen. On 35% oxygen, your sat should be 100%. Hers aren't. So you need to explain it. The point of care testing is lovely, but you've got to look at all the bits in it. Okay, next slide. Next one. All right, here we have a normal pH. The CO2 is low, hence we're going to have two primary processes as our flow diagram said. But from your point of view, you already know that. Your base excess is negative, so you've got a metabolic acidosis. You're going to have a respiratory alkalosis. But if I want to do the raw numbers, I expect on that the CO2 to be 38. It's 32. So you've got two primary processes. My metabolic acidosis here, 149 for 120. 120 is too high for 149. There is my normal anion gap metabolic acidosis. And I have a respiratory alkalosis as well. The patient is sick. The patient is slightly hyperventilating, but not just that. Look at our lung unit issue. We're on 30% oxygen. I must have pathology in my lung as well. I must have leaky lungs. Look at it. My AA gradient is large, isn't it? So this is someone with leaky lungs. They may be septic from a lot of places, but a chest X-ray here is not going to be normal. It is going to show infiltrates. It is going to show a bit of collapse. And the infiltrates, as we come to, if we do a chest X-ray, one can only ever be red cells, white cells, or water. They're the only three choices on a chest X-ray that makes it white and fluffy. But there'll be something in the lung unit. It can't be normal on that. We need to look at it. Okay, next. And there's the rest of our electrolytes there. So we see we have there's our anion gap acidosis. You don't need to know about the rest. I just put them there for completeness to show you the albumin is 26. If you go back to the slide before, there is why your anion gap is 8. If we do go down to the next slide, however, we can look at a whole lot of stuff and we can do different lectures on what blood tests mean if you want, but out of those you can figure out that we have something wrong with your liver, not because the enzymes are wrong, I don't care about that, but you've got a conjugated hyperbilirubinemia. So now we better go find the cause of that. Is it cholestatic or not? And the enzymes tell us the cause. That's the important thing. Okay, we can also say the patient is dehydrated, your urea to creatinine ratio is high with a bit of renal impairment. We can come to that on another day as well. So that is the rest of the bloods that when you ring us or you take and we get hours later, that is what we'd go and look for on those bloods, which will give us far more information. Your point of care test tells us they're sick. So let's go back to the slide before. Here is your point of care test. You've told us they've got a mild metabolic acidosis. Yes, we know their CO2 is too low, so we've got to explain that. They've got a high AA gradient. So we're going to have lung pathology here, and we're resuscitating with normal saline. Okay, we already know that, and you've rung us. That's fine. We then go to the next slide down. We look at that and we see you've got a conjugated hyperbilirubinemia with predominantly a mild cholestatic process. So, gee, I've got something wrong with my liver, and I'll bet my chest x-ray is going to have some infiltrates in the right base, because I guarantee you that's what a gallbladder would look like. Chest x-ray will be a bit abnormal because I've got this nice little bit of pus below it, haven't I? Patient's a bit dry, as is indicated by the urea being high and the creatinine being relatively normal. Done, finished. And the 152, 120 is just the normal saline we've been using to resuscitate the patient. So this might be someone who is frail, has a bit of cholecystitis, is going to theatre, is breathing hard, has some right lower lobe collapse, maybe some fluid there. This would all fit very nicely. And all of that's there on the bloods, but you can get it from the point of care testing. Next up. Oh, if we go back one, just go back. Go back. The reason you would ring us is the 68 on 30 at your level. You would worry a bit about that. That's going to be all right in the ward. We just put it on high flow. But it's something that in the middle of the night we'd know about, because that lung unit can't be normal. And if this patient's going to theatre at night, we need to be looking at how to give them pain relief thereafter, don't we, to get them through the night and breathe up. Okay, next slide. Next slide, next slide. Next slide, there we are. All right, we're just about to the end, ladies and gentlemen. Normal pH, high CO2, and look at that, a high base excess. So we've got to have, from your point of view, a metabolic alkalosis and a respiratory acidosis. From my point of view, the CO2 should be 0.7 and 20, which is 21 and 20 is 41. It's much higher than that. So we can agree. So why not we have the metabolic alkalosis? Goodness gracious me. I said they're pretty rare. So anyone help me, do you think? It's not vomiting chloride, that's too high. So we've got to think of another thing. So one is, remember I said your albumin might be low, and the other one is, what drugs do we give you that start with S and end with eroids that push your sodium up? So steroids can do that to your sodium, and or Lasix can do it, but your chloride's possibly a bit high. But the really metabolic alkaloses are fairly rare. You see it in children who vomit with pyloric stenosis, but not many adults do. They're long sick before they do that. We're going to see it with albumin low, steroids and steroids and Lasix. Next slide. And now, whoever said before the terms, this is perfect for a chronic respiratory acidosis. Perfect numbers. But do you think that's likely, or go back a bit, go back a slide, or in the world into which you're going, do you think it more likely that this person is going to have treatment for whatever got them their chronic respiratory acidosis in days gone past? So this is why I caution you, really caution you to use trite terms. It is far more likely that you're going to have primary processes because we intervene than trite terms. And the only way you can use that trite term is to know the full history. And we rarely do that. So if in doubt, here I would say it's a metabolic acidosis with a respiratory alkalosis until I proved otherwise, is the safer option. Because if I go, it's just a chronic picture, then that means this patient is like this all of the time, and hence there's nothing we should or can intervene with. Doesn't make sense, does it? So we'll be safe and we go for the 2 primary processes, and you're not going to get yourself wrong in real life doing that. Next slide. And then the one after that. Okie doke. Just for quick terms, we have here, for those of you doing your base excess, minus 2.4, you've got a metabolic acidosis. And in raw numbers, I'd expect the CO2 to be 38. It's less than that, so you got a respiratory alkalosis as well. So in your world, for that base excess, you'd expect a CO2 to be something just under about 40. It's well under that, so you've got to have 2 processes. Your metabolic process, look at the chloride, 111 is about 5 high of what it should be for 143. So it's really just normal saline resuscitation almost invariably for something. Okay, next. Next. Ladies and gentlemen, I would think at the moment that should have just about done your heads in, and I'm not trying to make it difficult. What I'm going to propose to do is let's let that settle for a couple of weeks. What we'll do in a couple of weeks' time, if Athol or you want, is we can do any number of examples where you could have gone through this talk a couple of times, come up with your questions, and we can do a Q&A session if you want in relation to that, because this is a lot to take in for you to look at it slightly differently. What I'm trying to get you to do, unlike textbooks, is use this like a hammer. It is a tool. Think of yourself as orthopods. Bang the thing. It's not that difficult if you follow the flow diagram. So do the examples we've done, follow the flow diagram, and if you want, I can put together a session where we can do any number of these for you together, and we can come up with answers that you can see that it is a robust system that will work for you to give sensible, coherent answers. Because at the moment, I appreciate it is overwhelming. And there's no way around it. It is, until you get used to it. It's just a slightly different language for you. Does that make sense? Are you all going, just go away now? I'm sure you are. All right, we'll do that if everyone wants. We can do that in a few weeks' time. What we should do is do this. I've got one coming up in a couple of weeks, Athol, for trauma, which we'll do that over 2 sessions, I think. We'll take you through trauma from woe to go. Will that work, Athol?
Yeah, I think fortnight's time, trauma 1, 2 weeks after
and then
that, trauma 2,
and then we might come back and do this.
Yep.
And
probably
then
in 6 weeks' time.
Yeah, whenever you want it. Yep. And then it might be prudent to do, you want chest pain, is that right?
Yep.
Yeah, all right. We want a rational approach to chest pain for you, which takes away all the silliness about taking histories. I'm an intensivist, I don't do that. So we can do the how to do chest pain 101 for you. How to read ECGs in a practical sense would probably work. Yep. And then we might I was thinking we might do chest x-rays and CTs, how to read them. So at least you can get a little view so you can read them fairly accurately and fairly quickly. So by that time, you should be equipped to do point of care testing. You should have a robust system that we did last time. We're going to apply that system to trauma and take a patient on a journey with that one. And then we can do this again. We can do these worked examples, some chest x-rays and things. And lastly, then I think you want toxicology. Is that right?
Correct.
A practical guide. Yeah, we can do a practical guide to toxicology for you. So that might help a little bit. Will that suit?
Yeah, that sounds really good. All
right.
Okay.
Bye-bye.
Thank you, everybody. We'll see you in 2 weeks.
I'm
Thank
sorry
you, Kel.
it's difficult tonight, guys. It's just a bit harder to do than the last one. So go through it and then we'll do some worked examples in a couple of weeks. When we do the trauma one, there are gases in that and we'll work through the various gases at the point through the journey so you can see what's happened and why we do things and then correlate it with x-rays, because what I've got is a patient from woe to go for you with the physiology that goes with it. So we'll do that, eh?
Yeah.
Hey, Greg, are you all right if I distribute the slides to the students attended this evening?
I assumed you already had, mate. I'm sorry.
No, well, we don't actually know who's going to attend until they come along.
Oh, I see. Oh, okay.
So,
Yeah, of course you can.
Jason's
can.
just asked.
I
and
assumed the
so-
guys had them. Sorry.
No, you're all good. I don't know, but those who need them, I'll send them on.
Yeah, absolutely. Yeah, of
Yeah.
course you can. So you've got them. You can then work through the ones we've got, and then we can keep them or put them on a separate bit of paper, and then we can go through your flow diagrams for the bits when we do more, and we can work through them together. So that'll work, hey?
Yeah, the whole lecture will be
much
on
better.
cis as well.
Yeah, okay, cool.
Yeah, it will, but I think, the slides would be lovely for them.
Yeah,
Now, the flow diagrams, for base excess, the ones that I've put together for you as a group, there are none out there in the literature. What I've done is put together what we do in raw numbers and then translated that to venous gases for you and base excess to give you some meaningful point of care results. So you've actually got those fresh off the press. There's nowhere else in the world has got them. So there you go, guys. Brand new for you all. All righty.
okay, thank you, Greg, thank you, everybody. Back
Okay,
again in 2
bye-bye.
weeks. Okay,
Okay, bud.
bye.
Catch
Thank you,
ya.
everyone. See
See
ya.
everybody. Ciao.
Bye.